All right. Well, if anyone's listening, I don't have really a lot of feedback right now, but I am going to do a 10:30 start. It's 10:28, so I'm going to give it a couple of minutes. If anyone is here, I just want to let you know I have a lot of material and I may lose my voice, so I'm going to try to avoid that. But to the people I see in the room, I just want to say thank you to AROC for one, letting me do this. Two, at the same time, I think it's a very timely lecture. And so it's I'm really glad to be able to bring this to everybody. And hopefully we'll have enough time for the Q&A as well. So just in another minute or two, I'll get started. And I appreciate everyone attending. It's good to see a lot of fellow osteopaths. It looks like we have around 130 some odd people so far here, which is great. I hope everyone's having a good spring and is being safe with COVID. And that also includes Dr. Desai. Good to hear and see you here too in the chat box. Okay, without further ado, I have 10:30 on my clock, so I'm going to get started. So once again, I'm Dr. Daniel Berger. I'm coming from working out of Capitol Health Medical Center in Hopewell, New Jersey, and I'm very happy to attend AROC to present this lecture for you, which is extremely timely, as I think we're all aware. We're going to be talking about possible solutions for decreasing the United States Black maternal mortality. And I must say that I'm very grateful to give this lecture, and hopefully we'll all get something out of it. So let me see if I can get things to start. First and foremost, I have nothing to disclose as a CME event. And in general, with my lectures, I try to make sure that I always give credit to where credit is due for teaching me something. Some of you may have understand this slide with Isaac Newton being, if I've seen further, it is standing on the shoulders of giants. Dr. Britt Bloom is a medical student who is graduating this year. I must give her credit to the idea that she prompted me to drill down on this topic specifically, knowing that I have a particular interest on maternal mortality, and really with the idea that it is important to focus on Black maternal mortality. And so I hope, much like many of us understand that we're all colleagues, and this is one of my future colleagues who is now my colleague as an osteopath as she's graduating this year. So I'm going to show you this video that I have permission from Mr. Johnson. And if you've seen a lecture in the past on overall maternal mortality, I think this is a very pertinent one, even when it comes to Black maternal mortality specifically. So please watch.
So mommy, where you at?
Beautiful Palm Springs. Daddy surprised me.
So let's talk about this woman who is Kira Dixon Johnson. We're talking about a woman who was far better than I ever deserved and made me far better than I ever thought I could be. We're talking about a woman that raced cars, who ran marathons, who had her pilot's license. Talking about a woman who spoke 4 languages fluently and who taught me so much, not only about myself, how to be a father, but just about love. We walked into Cedar-Sinai Medical Center with Kira on April 12th of 2016 with a woman that was not just in good health, she was in exceptional health. Hey, Mommy.
Hi, Daddy.
Hey, Lexi.
Hi.
She went in for the procedure. Shortly after that, we were taken to delivery. God blessed us with another substantially, amazingly healthy, beautiful baby boy. Shortly after that, Kira sitting in the bedside, and I began to notice blood in the catheter. I alerted the nurses and the medical staff. They came to her attention. They examined her. They did several things. They ordered a series of tests of blood work. Around 4 o'clock, they ordered the CT scan that was supposed to be ordered stat, and I understood that to mean immediate. I was concerned, but at that time, I understood that there was a plan and I could live with that. 4 o'clock comes, 5 o'clock comes, still no CT scan. 6 o'clock comes, they perform an ultrasound. They see that her abdomen is filling with fluid. Her blood work comes back. It shows that her blood levels are dropping. She's beginning to lose color. She's shivering uncontrollably. When they examine her, she's sensitive to the touch. So by 5:30, 6 o'clock, there were very clear signs that she was hemorrhaging internally significantly. 7 o'clock comes, still no CT scan. 8 o'clock comes. I'm begging, I'm pleading. My family is advocating for my wife. Still no scan. 9 o'clock comes, they say that they need to do a blood transfusion. And I ask and I'm begging again, do something. Where's this CT scan? I thought it was supposed to be performed stat hours ago. At which point the staff at Cedars-Sinai Medical Center tells me that your wife isn't a priority right now. 10 o'clock comes, still no scan. 11 o'clock comes. It was not until after midnight that they finally took Kira back to the OR. As we left the recovery room and walked down that hall to the OR, and I'm holding Kira's hand and she's telling me, baby, I'm scared. And I'm doing everything in my power to just remain calm and tell her everything's gonna be okay. The doctor says to me, I'm gonna go back into the same incision I made. She'll be back in 15 minutes. And that was the last time I saw my wife alive. When they took her back into the OR, they opened her up and there were 3.5 liters of blood in her abdomen. And she coded immediately. Kira deserved better.
Always so tragic. I am truly grateful that Mr. Johnson has given me permission to look at this video. And for those who have been at AROC in the past when I've lectured, I've used this video before, but specifically, I'm making the point today, this poor woman died from a hemorrhagic shock. And the question is, did racism play a part? He poignantly says that she was not a priority. And as a human being, that's just not acceptable. So today we're going to review issues associated with maternal mortality in the US overall. We're going to discuss factors and solutions for Black maternal mortality rate in the US, which is particularly tragic. And we're going to focus on social determinants of health, bias, and racial disparities and how that plays a part. So the first main issue is it's an ethical issue of equity. And you can see by this graphic that comes out of California, or just looking overall at the US maternal mortality rates, is that for Black women, they have 3 to 4 times the rate of maternal mortality and double the risk of severe maternal morbidity than white women, which is horrible. And if we're ever going to make a difference in maternal mortality in the US, which is high, we have to focus on what the issues are that are specifically to Black women from an equity standpoint, for sure. And so we must address racial disparities. As physicians, as osteopaths, we have certain things that are important. I'm just going to read this. Not only in the name of justice and good health for all, but also because it is a moral and ethical imperative for us as physicians to look at this issue, tackle it, and take care of it. And we will not, as I said before, be able to solve maternal mortality unless we have a frank discussion about racial disparities, because it really is the elephant in the room. We can't ignore it, just looking at that data that we just talked about. So I've given this lecture before, and I will tell you that in giving it last year, it really was an up-ramp. And I want to go through a couple of things in each one of these particular points that it's getting more attention, especially now in the with the rulings that have been going on. But last year, and you can read, without an ounce of empathy is what they felt, this one woman felt. And that was September 8th, discussion of the Black maternal mortality rates and how implicit bias is a part of it. Quote, the day I was reduced to a Black birthing body, a doctor, family practice, reflects on her pregnancy. From the New York Times, Protecting Your Birth, a guide for Black mothers, how racism can impact your pre and postnatal care. And tragically, in Indianapolis, a pediatric resident, Black doctor dies after giving birth, underscoring maternal mortality crisis. Those stories are just endless at this point. So I can't cover everything that involves, that leads to disparities in perinatal health, but just you can see on this chart that there's societal factors, there's community-based factors, individual factors, relationship factors, and they all drill down and can cause this levels of disparity. But it's our obligation to try to mitigate all of this because we have an obligation to prevent death when possible. So we're going to go through a couple of definitions. So first of all, healthcare quality cannot occur without healthcare equity. And so we're going to go through the definitions of equality and equity, and these pictures give a good understanding of the difference. So equality is the state of being equal, especially in status, rights, and opportunities. As you can see with everyone receiving the same bike, that doesn't mean that it works for everybody. As compared to equity, where no one is denied the possibility to be healthy for belonging to a group that has historically been disadvantaged. In other words, the tailoring of care, or in this case, bicycles, so everyone can hopefully do what they need to do. Other definitions, health disparity is the health difference associated with economic, social, or environmental disadvantage. And it tends to adversely impact people who have been systematically experienced greater social or economic obstacles to health, and it can be quantifiable. It's separated from a reference point, usually the most favorite group rate. In this case, for the conversation we're having, white pregnant women. And health inequity is the health differences that are unnecessary, avoidable, and considered unfair and unjust. As I mentioned, I've lectured for the past several years on maternal mortality nationally. All US women are more likely to die from childbirth or pregnant-related causes than women in any other high-income country. It truly is a tragedy, and it is an epidemic scale. And you can see by this chart, as it says up top, that we're ranked 65th compared to other industrialized nations. There's many reasons for this, but the point is, other countries are doing a much better job at preventing maternal mortality for a variety of reasons, in particular, Black maternal mortality. So background again, overall, the risk of US maternal mortality is roughly 1 in 4,800 women will die in childbirth or related to childbirth. That's roughly 700 to 900 maternal deaths a year. If we had the rate of California, that would only be around 119 to 153, because every state does it differently. Unfortunately, as mentioned before in prior lectures, New Jersey has a particularly high maternal mortality rate. But overall, for the CDC, made a statement and data that 60% of all maternal deaths are preventable, which would reduce the number to 280 and 360. And as we said, Black maternal mortality is at a much higher rate, and therefore we need to make a difference. Further, for every one maternal death, we get close with severe morbidity 100 times. So the point overall is that too many women are having complications and dying, and this just isn't acceptable. So here's a list, and I'm not going to go through them, but the point is there's many ways that we can possibly look at to make maternal mortality less. And I'm not going to go through everything. It's an exhaustive list, and it's not complete even on this page. But today we're going to focus on Black maternal mortality. So I've tried to break this down into systems, patient, personnel, provider, and with that, there is overlap. So please bear with that, but we're just going to try to cover as much as possible. So first, we'll start with systems-related issues. And the main comment I'll say, and I'm doing this on purpose, is if we had the safest care for everyone, wouldn't that impact Black maternal mortality? And the answer is yes. If all maternal mortality was reduced, that would be a great thing for everybody. So that means from a prenatal standpoint, doing prehabilitation and optimizing everyone to the fullest degree before delivery. Intrapartum, giving this absolutely the safest care for everyone, having an optimized environment that a team works synergistically. And postpartum, making sure that all care that's given is integrated well into the rest of healthcare so that OB is not in a silo and people fall off. And that form of standardization is something that we're all striving to go through. You know, I have this slide from before in prior lectures discussing the idea of implementation of checklists, standardized protocols, trying to reduce variability for one patient versus another, using cognitive aids to make it easier and safer, and focusing on becoming a highly reliable organization, having healthcare overall being a highly reliable organization, but in particular with obstetrics, having an expert team instead of just a team of experts. In other words, working well together with one another, collaborating is absolutely crucial for optimizing and reducing harm and preventing error. As many of you might remember James Reason's Swiss cheese model of preventing error, and whether it be the latent weaknesses in a system, but anything to prevent harm. So this is also a general slide. If we have Swiss cheese and we want to change it to Havarti, which has much smaller holes, it would make the system safer. So there's some generalized statements here of examples of how we could make a system safer by not having multitasking, reducing our high volumes, having better sign-outs, having appropriate backup, good teamwork. All these things play a part to make a whole system safer, which would then benefit, you would think, Black maternal mortality. And that is true, except the point is an overall safer system would go ahead and reduce the overall number. But as it says here from a quality improvement standpoint, if we all rising tides raises all boats, but I know a few more boats that are full of all holes. And that's the point. If you look at the graphics on the side, all that will do, it will reduce maybe the number, but it will not go ahead and accomplish a reduction in the rate of Black maternal mortality. It will still be 3 to 4 times greater. So racial disparity will lessen when it's seen specifically affecting Black women. And this is what we want, this arrow pointing down here to show improvement or narrowing as compared to a widening or it's staying the same. So fixing the system for everybody is great if it would reduce it to 100%, but we want to reduce rate. So here's some evidence-based bundles, because this is now part of the picture of obstetrical care, where we're trying to deploy standardization throughout systems and tailoring it so that we can reduce harm from all these are issues that cause complications or maternal death. So here's a bundle on obstetrical hemorrhage, venous thromboembolism, and hypertension. And these bundles do a great job of reducing rates. And they're like the top 5 main causes are listed here: VTE, hemorrhage, preeclampsia, infection, cardiomyopathy. And Black women are more likely to die from these causes. So the absolute number will go down, but it's not going to drive down the rate of disparity. So it's important to understand that these other bundles are very good, and we are seeing a decrease overall, but we want to impact Black maternal mortality. And so I contend, and this is the purpose of this lecture, is that racism actually makes larger holes in the care. And this is what we want to avoid. This is what we want to take on head on. And this is what we're going to get into today, because we can't afford that disparity rate. And so here's a great example of how someone, because they are Black, gets dismissed. And so it's not often it's race, but it's racism. So very famous case, Serena Williams, who's still alive, gave birth, and I'm gonna have to move my picture over here so I can see my, I'm so sorry, my slides. She gave birth, and she knew that she had a history of a PE. She knew what that felt like. And she actually went up to her staff that were taking care of her. And she's like, I'm short of breath. And they actually turned to her and said, no, we don't know if you really have a problem. They didn't believe her. And she was adamant. She had to advocate for herself to say, no, I need my anticoagulation. I know what this feels like, and so forth. The staff that were taking care of her dismissed her concerns. They didn't believe her, and that there's no other words for it. So as a solution, beyond making the overall system safer, if it can't be perfect, we need to actually deploy a bundle that actually tackles racial and ethnic disparities. And we actually have one. So we're going to go into this and go through several points of it. And it's referenced accordingly here if you want to read more. So the first thing is, and I would advise, is that we need to truly identify and measure racial disparities. So how do you do that? Quote by Ed Deming, you can't manage what you don't measure. And here's an example of that from the CMQCC, which comes out of California, where they actually tracked, and you can see at the top line that the rate for African-American maternal mortality over a decade has remained higher than that of the reference group, of which in this case is white women down below, is also Hispanic. And that, as seen by the graphic here, there's no change. So having data that properly identifies a patient by race, ethnicity, nativity, and language is crucial. So we can actually say, hey, there is a problem. And having the patient agree to letting their data be collected, having the staff educated on the importance of identity of the information is crucial. And so let's look at New Jersey. So we do this routinely, and you can see some unfortunately terrible situation in 2018 where the rate for Black maternal mortality compared to the rest of the US, we are much higher. And versus the reference group, we are much higher. And so when you look at this and you actually calculate a ratio, you can then compare it year after year after year. And so back in this comparison, you see it at 3.4. So when we move forward to 2019, we can actually compare. And we now see that it's 3.79. It's worse. The gap has gotten wider. So we really need to really look at the data and measure and collect it. So data allows one to see and tailor corrective action. I see there's a hand raised. We're going to answer questions at the end. In looking at this, you can actually further break it down, as in the CMQCC has done, and you can measure it and then stratify where you want to potentially target to make more of a difference for the group that has inequity. So as you can see over here to the right, Hemorrhage happens to Black women in this subset in California to a much greater degree. So you could possibly reduce the impact and make a stronger hit to Black maternal mortality by dealing with hemorrhage much more aggressively, or sepsis, or for those that need transfusion. So it's important to take those measurements. Now, with that said, I'll also throw this out. Not everything that counts can be counted, and not everything that can be counted counts. Not my quote, it's William Bruce Cameron. And the point is that other things matter when it comes to racism. And what I'm talking about, it's anecdotes, impression, the perceptions of the patients and of the people that are involved. So this is Dr. Liggett. She gave birth, as I said, good article on her experience. And literally every system of healthcare, every department, we need to actually ask and know what your individual Black patient pregnant stories are. We have to see what they perceive. We have to listen to what their needs are, because it makes a difference. How are we supposed to know how they feel unless you get their stories? The idea that this is her perception of care. She is a physician in New York, in the Bronx, the day I was reduced to a Black birthing body. Unbelievable. Quote, she treated me as if I was a piece of cattle. Quote, I think that my doctor dismissed my concerns. If we don't minimize traumatic experience, if we aren't able to perceive that we're being traumatic, how are we supposed to make a difference? How are we supposed to lessen the emotional and biological stress that they feel as our patients? In addition to hearing her stories, we need to actually ask the question when something goes awry, and it should be routine. Was racism involved? It may be on an interpersonal level, a system level. I'm saying that every time we come close to having a bad outcome or a maternal death, we need to actually ask the question to make sure that this is not occurring, that racism doesn't play a part. And to me, this is what it means to be part of a highly reliable organization, to perform as it's intended consistently over time. We have to make sure there's no institutional bias, because we should be looking to be a just culture, a balance of system and individual accountability in a manner that best supports the system's safety and other organizational values for all. Racial inequities that develop from cultural values, frameworks, and institutional policies must be dealt with. We can't afford this. And there's examples of where this can be done on an institutional level. This is one hospital. I have not put it in by name, but they basically made a calling card saying that they wanted to address the culture of racism in their system. So what they did, they defined the scope of the problem and built a case for urgency as a burning platform. They started with 3 things. 1, respect. They defined actions that were taken towards others that protect, preserve, and enhance dignity, and they demanded respect for patients and visitors and staff, for everyone. Anytime there was a complaint or grievance of disrespect, in this case, racism, they set boundaries that required action. And they coached. They were not punitive. They explained to disrespectful staff on how to prevent future harms. The idea was everyone deserves to be treated equitably. And that's what part of being a just culture is about. With that said, there's many factors, as I mentioned before, that can contribute, and there's many strategies that can be applied to preventing pregnant-related deaths, whether at community, health facility, patient, provider, or system levels. We're going to skip to something specific, and that's about trust. 1, we have to be building trust in the healthcare system within the Black community, because there is a long-standing history of a lack of trust, and I behoove everyone to keep this in mind. I can't write this better or read it than it's read. And this is from Dr. Manning. It was in Lancet. We need a seismic shift in our relationship with Black lives, as demonstrated through government and societal actions, policies, investments, and outcomes. Medical mistrust is just the tip of a 400-year-old iceberg that has to be chipped away from every direction. It's very worth reading and very timely, because I think we all understand the history that goes back with medical, in the medical field, that unfortunately there's many examples of when the African American or Black community has had distrust and have reason for it. Classic is the Tuskegee experiment with untreated syphilis. Henrietta Lacks with not having consent for her immortal cervical cancer cells. To go far back, Dr. Sims, who's considered by some the father of American gynecology and experimentation on Black slaves. But these are really remote. These are in the past. Is this really relevant today? I would say that it is, but there's other current examples. Here is Fannie Lou Hamer, who gave an example from the civil rights era, quote, in 1964, in North Sunflower County Hospital, I would say about 6 out of 10 Negro women that go to the hospital are sterilized with their tubes tied. That's without permission. And that figuratively has been called in the past a Mississippi appendectomy. Tragic, but even more current. I'm going to show you this video and why it is not, while it is not a maternal case, it is a very poignant case. So this is Dr. Susan Moore, and I just wanted to let you hear her voice.
This is the second worst day here at IU North. Yesterday, Dr. Bannock, B-A-N-N-E-C, wanted to send me home. You know, at that time, I'd only received 2 treatments of the remdesivir. He said, you don't need it. You're not even short of breath. I said, yes, I am. Then he went on to say, you don't qualify. I must have, because I've gotten 2 treatments. And then he further stated, you should just go home right now. And I don't feel comfortable giving you any more narcotics. I was in so much pain from my neck. My neck hurt so bad. I was crushed. He made me feel like I was a drug addict. And he knew I was a physician. I don't take narcotics. I was hurting. So I spoke to patient advocate who left me wanting. There's not much I can do. So I started asking, send me to another hospital where they can treat me. And if they're not going to treat me here properly, send me to another hospital. Well, next thing I know, I'm getting a stat CT of my neck with and without contrast. The CT went down a little bit into my lungs, and you could see new pulmonary infiltrates, new lymphadenopathy all throughout my neck. And all of a sudden, yes, we'll treat your pain. You have to show proof that you have something wrong with you in order for you to get the medicine. I put forward and I maintain, if I was white, I wouldn't have to go through that. And that man never came back and apologized.
Just tragic. But the point is, in order to gain trust, we have to prove that we're trustworthy. So how do you do that? Another solution, we have to actually become part of the community and help with, and on a healthcare system level, we have to connect. Here's another statement, quote, I think that there have been, I think there been a white woman of my same age, of my same situation, that her doctor would have looked at to why is this happening. This is someone who unfortunately suffered a term stillbirth, which is tragic. So we need to, on a multi-tiered level, whether it be a personal provider level or in this case system level, we have to have continual outreach and presence in the Black community. We need to engage local community on hospital committees so they can be a part. We have to make sure we have a welcoming environment. We have to listen, as I said before, hear her story. We have to walk a mile in their shoes. We have to see what they're experiencing. And we have to recognize that there's a connection. Racism is traumatic. We have to acknowledge that prior experiences, whether from generations past or current, are actually traumatic. And we have to avoid re-traumatizing people. We have to, as mentioned before, coach, retrain, and create a just culture, because trust is the foundation between a patient and the provider and the healthcare system. It's all interconnected. I will also make the point that there's a lot of people that can't afford and have known people have died because they can't afford healthcare. And with that, that comes to another solution, which has recently been passed as far as getting dealt with, and that's the Congressional Black Maternal Health Caucus, which is the Black Momnibus, has been reintroduced as of this February to impact racial disparities and a variety of things. Due to time, I'm going to speed along, but you can always look into this on how it can make a difference. At the same time, the recently passed American Rescue Plan Act can make a huge difference, regardless of anything, race specifically. Medicaid is the single largest payer of maternity care in the US, and that's 43% of all births in 2017. That number is pretty static right now. If all states were to implement Medicaid expansion, uninsured women from ages 19 to 64 would decrease from 20 to 8%. And I will tell you that is a big issue as far as people falling off. Medicaid usually ends at 6 weeks. If that were extended for a year, that would do a tremendous amount of access and less what's called insurance churning, and therefore make a difference in the potential rate, specifically also for Black women. Another solution that would help make a difference is diversity. It should be the rule and not the exception. And just looking at this group, we need to make sure that the healthcare institutions are reflective of the community as far as trust and having people look and feel in a heterogeneous environment. In particular, in our own background, Black medical students represent only 7% roughly, when the overall US population is 13%. There may be an issue here. In addition, let's take a look at provider relation issues. Another solution is to actually connect to humanness, provider to patient. Trust, mutual respect, and understanding between the caregiver and patient are crucial to optimizing therapeutic outcomes. This is part of our osteopathic holistic philosophy. We need to humanize our patient. Ask the patient, quote, is there anything you would like me to know personally as a fellow human being that would help me give you the best care possible? I often make the point to my patients that I would take care of them as if the patient is my wife, my daughter, my mother. Connect to them. Seeing a patient as an individual human being reduces the power of stereotypes and promotes trust in both individuals. And that feeds into the implicit bias. We need to have an understanding of what this means. Implicit bias is the unconscious. You're not thinking of it. It's not explicit. The unconscious prejudice for or against a person or thing, and it's usually unfair. It does impact a clinician's perception and decisions. It creates disparities in access, interactions, treatment decisions, and health outcomes. It's extremely relevant in situations that are prone to cognitive overload or high stress, such as labor and delivery, the ER, or critical care, because we, as human beings, use implicit bias to survive. A reliance of unconscious processes and activation of stereotypes and unconscious beliefs that are more frequent. They may be counter to your own explicit intent, but it's there. It's not overt, it's not intentional discrimination, but it does result in discriminatory behavior and what people perceive. And you can test yourself by actually going to this website, which I would recommend, to see where your implicit biases are. We all have them. It's normal to have them. It's not acceptable to allow them to impact your care. And here's some examples, what you'll see on the website, whether it be tone, ethnicity, weight. And by knowing these, we can have a solution, because you can know your personal biases and be mindful of them so that you can recognize what is acceptable, but can be potentially harmful unconscious processes that lead to bias. To help decrease that implicit bias, we can foster these things: intergroup contact, perspective tracking. You can do storytelling. Do you really know how other people feel? Like I said, hear her story. Individuation, focusing and making sure you look at a person as a human being and individual rather than someone from a social background. Programmatic training and workshops, kind of like this, the idea of talking about it, but actually going through training that can hopefully know what implicit bias is. And then being an active bystander. If you see implicit bias creating harm, doing something about it instead of dismissing it. I can't go through everything, and some of these seem like they're not focused on how to cure Black maternal mortality, but they do combat bias. Washing your hands, identifying conscious and unconscious bias, using teachbacks. I'm going to skip over and just go, hold your institution to provide culturally competent care. We'll get into more about that later. Being aware of health literacy. All these things have been recognized as ways of helping to combat bias. Specifically, cultural competence versus cultural humility. Let's define this. Cultural competence, which most of us in the state of New Jersey have been required to get CME training on, suggests that tools to address cultural differences and beliefs that may influence a patient's decision-making, that we would be, quote, competent, which kind of implies the idea that culture is a skill that one can master. I would take and contend, as a white male, even though I am an advocate for women's health, I am an OBGYN who has dedicated his career to taking care of women. I will never truly be able to understand what it means to be a Black pregnant woman, but I surely am humble about it, on that I know that there's a problem and will support. So cultural humility may be a better term to use to suggest that the clinician is humble about recognizing the limits of his or her knowledge of a patient's situation, avoiding generalizing assumptions, being aware of clinician and patient bias, ensuring mutual understanding through patient-centered communication, and when appropriate, asking open-ended questions about a patient's circumstances and values. What also goes along with this is providing trauma-informed care, which is something I think most of us try to do and will do. Trauma does not have a universal definition, but from SAMHSA, it's defined as the individual trauma results from an event, a series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening and has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, and spiritual well-being. Here are several examples, and I will tell you that if you don't think racism does this, I will gladly say that you're wrong, because I have had my fair share of experiences of taking care of Black women and their families, and without a doubt, the fear and the trauma of racism makes it hard for them to get the care they need, and it is truly traumatic. So in providing trauma-informed care, the goal is to decrease the toxic and traumagenic interactions and circumstances so that both staff and clients experience health care as a safe, supportive environment. And that focuses on safety, trustworthiness, peer support, collaboration of mutuality, empowerment, cultural and historical and gender issues being taken and understood as part of the issue. In addition, as providers, we need to be aware of something called the weathering phenomenon, and that it's driven by a racist environment. We know Black women have increased clinical risk for venous thromboembolism, hemorrhage, preeclampsia, infection, cardiomyopathy, gestational diabetes, preterm delivery. Well, why does this occur? Why do they have higher rates? Why does someone like Lieutenant Commander Shaylon Irving, why did she die from cardiomyopathy? This is an individual, and it's a great story, tragic, but a great story that typifies this issue, that education and economic stability does not eliminate the disparity that race and ethnicity brings to maternal mortality. This is an individual that studied this very issue. She had a BA in sociology, 2 master's degree, a PhD in this subject of disparities. She worked for the CDC. She had insurance. She had a support system to beat the band. And she ended up dying because she did not get her cardiomyopathy treated effectively. If she can die, how is any Black woman to survive? How are they supposed to feel safe? And when you look at it and you say, well, you can educate yourself to safety, as I mentioned, you can't. Here is a chart that gives you an idea of the rates of death associated for Black women who have a high level of education. And their rate is much higher than even if a high school graduate that happens to be Caucasian. And it goes back to this hypothesis by Arlene Geronimus. She's up in Michigan and has been studying this now for 30 plus years. She went ahead and looked at the weathering hypothesis to explain that premature decline in the health of African-American women is because of stress and dangerous environments, and the general social disadvantage causes a wear and tear on Black women. And it is actually supported by biological markers of allostatic load and telomere length, where the biological age far surpasses what the chronological age, going to the idea that zip code is more important than your genetic code. And it's shown by this graphic. What is biological aging? It's the progressive accumulation of oxidative stress and inflammation that has damaged cells and the body to the point that it can't manage the way it would if it didn't go through that. And you can see that the normal way of maintaining homeostasis is with certain stressors, your body can recover. But when it's impaired by chronic stress, it ends up having damage and predisposes oneself. This is dermatoheliosis, and this is a truck driver to show an example of how environment can cause chronic damage and wear and tear. It's the physical exposure that causes a phenotypic expression. Do not put it past the idea that a toxic environment and exposure leads to premature aging and disease manifestation, as I just suggested, for Black women. And this is what it is. Racism and the US lifestyle is the risk factor whether it's perceived or real discriminatory practices, they are contributors to adverse birth outcomes among racial and ethnic groups. And by this chart, you can see, coming from the inequity, you have a chronic stress that leads to obesity, epigenetic changes, oxidative stress, inflammation, undue sympathetic activation, as well leading to these chronic issues and susceptibility, which leads to maternal mortality. To the point that Black women, as I said before, they have double the rate of maternal morbidity. They have more chronic conditions than other groups. They have pre-existing conditions that are more double compared to white women. To the point that when they have this over a lifetime, as this chart shows, the level of comorbidities that Black people have, Black women, that this causes harm and predisposes them in a dose relationship. So, as I've said in other lectures, we have to realize that as a population overall, we're delaying childbirth for a lot of people, but 40 is not the new 20. 40 is 40, right? Because in general, and this is a general slide that shows that maternal mortality increases as you age. For Black women, if we look at this chart that breaks it by demographically by ethnicity, we can see that when you look at the more younger age and you compare to the older gravida, and you look at Black women versus white women, the rate of death for the older gravida is much higher. What does this mean? This means that because of weathering, Black women, whether if they're 16, 20, 25, or older, they're actually chronologically maybe that age, but biologically, they're at a higher age overall, and therefore they're more likely to die. So what are some patient-related factors that go into this? We need all women, but in particular, Black women, it is more prominent to get prenatal care, to get best outcomes. Prehabilitation is preparing one's body and optimizing the physical and mental condition before delivery, whether it be gestational weight gain, whether optimizing blood sugar control. These are important facets to make the best outcome. They have to be in the best mental and physical shape before they go on the delivery process. They need to be more resilient. They need coping skills. They'll be better patients if they are. Resilience is behaviors, thoughts, and actions that can be learned and developed. And this allows them to have better functioning with adversity, trauma, and tragedy very quickly, supportive relations, realistic plans, communication skills, having capacity to manage strong feelings, having different strategies to cope, having good family and social connections to survive, avoiding crisis to crisis, accepting change as part of living, taking decisive action. This is good for all, but it may be more pertinent for the Black maternal patient. In addition, for everyone, and specifically for Black patients, having good patient education is a common quality improvement opportunity to better know what to look out for so that they don't die. And we are trying throughout, from a systematic standpoint, to go ahead and make sure that we give health literacy and informing our patients without scaring them so they know what to look out for, making it language appropriate and in ways that are not scarring at all. We also have to make sure that we follow up and are aware of what is being said to our patients. I will give credit to a colleague of mine who's graduating from her residency. This is a graphic of Insecure. It's a show on HBO that details the life of young Black women. And my dear colleague, Dr. Bianca Hall, gave some advice. She did a nice podcast of self-advocacy with her colleague, Dr. Smith, to advise Black women what to look out for. to become prepared when they have a visit, to be willing to answer questions, to ask questions, and to prevent over testing, which may not necessarily be good care, and to know options. And with that, for the patient and provider, connecting to them, making sure they're on the same team, building that trust, having communication, being health literate, making sure communication is which is a cornerstone of quality care and patient safety. I put in the Seracom phone not to designate it, but to make sure that we have good communication regardless of language background. I make a big point, I'm a big advocate for team steps as far as the interrelationship of teams, but we have to make sure that the Black pregnant patient is on that team. They are a part of huddles, multidisciplinary meetings about their care, debriefing. These are all concepts that need to be applied with the patient as part of this, as part of this team. Because healthcare is truly complex. It has become incredibly hard for everyone to be engaged and interconnect. And therefore, to navigate it, we need to make sure that our patient is well part of that team. And with that, we are more receptive to advocates to help assist in making it safer for all. We all know that COVID, especially in the hospital environment, has made it that much more trying and isolating. We have to overcome this. And with that said, it does take a village to raise a child. It will take a same village to save mothers. And I will make a point of saying that doulas are a good thing, patient advocates are a good thing, so that we all work together. And we have to consistently try to, rather than creating silos and tribalism. I want to spend a little bit of time specifically on postpartum care, because there's no question this is a major issue and time period. Timing for pregnancy-related deaths, and this is a general slide, it is tragic that in pregnancy, women die around a third of the time, and 69% of the time, it's postpartum. A third of it does occur from delivery to 1 week after, and then it's 1 week to a year is another third. So with that said, we need to make sure that we focus on that area of time, specifically for Black maternal mortality as well. We need to be more engaged. We have to use technology to do so to make a difference. We have to give more handouts and patient education, and we have to risk stratify our patients who have these comorbidities, which do tend to happen for a lot of Black maternal patients. They need to be aware of what complications they've had to make a difference. In addition to that, if they do have complications and they're delivered, are they aware and do they have good follow-up? Are they educated about the risks of things that may be immediate complications or predispose them for the rest of their lives? Is everyone working as a team to optimize to get that subsequent result that they can live safely? So for example, for all my colleagues not in OB, if someone has preeclampsia, as happens often for a Black maternal patient, they, for the rest of their life, have double the risk of stroke, heart muscle damage, blood clot, and 4 times the risk of high blood pressure for the rest of their lives. They need to be risk stratified, they need to be seen by primary care, and they need to be followed. So we need to have a good handoff with our systematic setup so that our patients are getting the care when they need it, especially in the postpartum period. Because who's on the team? All of these people are on the team, and we need to make sure we have that consistent support because it's just too complex of a healthcare environment today. And I'm going to end with the idea that contraception is equally important, especially for the Black maternal patient, because if they don't want to be pregnant in the future, they shouldn't be. They should have that access. And if a woman is not pregnant, you clearly can't die from being pregnant. And that's what I have. I'm going to go now to the chat box and try to answer questions or the Q&A section to do so. Hopefully I can do this effectively for everyone. I'm just going to check the time just to make sure that I'm not running too far over. I only have a couple of minutes. So to what extent is maternal mortality influenced by access to care? And the answer to that in general is it's significant, and particularly Black maternal mortality. I would say that it does influence. Access to care is a big issue. Hence, losing insurance is a big issue. So getting seen is a problem. I'm going to just try to continue on this. Just a thought. I am a white family practice with over 30 years experience. In 2020, I've had 2 family members in my own hospital system receive horrible care. Sorry to hear that. I was there all the time. The biggest problem was hospital staff never entered the room. Hospitals are very understaffed. At least that my family had me to advocate for them. Nurses, doc, and staff sit at a computer and there is minimal interaction with the patient. Usually minorities have fewer people to sit and advocate for them. Perhaps in this day of overwhelming paperwork, there could be more staff actually checking in on the patients. I agree. The last question I see here, how does one effectively advocate and communicate one's concerns if you are the Black pregnant patient? I think the first thing is to open that dialogue in a way to advocate for yourself and say that, hey, I am concerned about my care. And if that individual is dismissing it, ask to speak to someone else, and don't stop until you have actually talked to someone who's going to advocate for your care. I will tell you, it is hard. And I sympathize with some of the statements that are said here, that it really has become a much more complex environment to go ahead and work in and be a patient in. I think we all collectively have to work together to try to come up with solutions of such that I've mentioned. I'm going to switch to the chat box to see if there's anything that is a question. I don't see questions. I do see one more question, which I'll answer for time. In New Jersey, there is a higher rate of high-risk pregnancies. Is this also greater for Black women? I'm also same question regarding age. I'm in family medicine and feel there is more and more women going through fertility treatment. Is this also higher in New Jersey, and is the greater for Black women? Wondering if Black women who are higher risk to begin with are being properly educated in the risk and to look out for. That's a lot to answer. The answer is that I think that in general, we'd be shocked to suggest that there's a lot of high-risk pregnancies in every state because of the nature of our population. But I think in New Jersey, there is a higher rate of high-risk pregnancies that we all see. I don't know if I'm answering the question effectively to say that there are high-risk pregnancy everywhere. When you look at the national data, fertility rates are actually dropping, but it's older gravidas because of the nature of our lifestyle in the US, we're delaying, and that's creating a lot more problems. There's a lot of, also, we have a very sick, heterogeneous population that has a lot of comorbidities, which saddles obstetrical patients with having other problems. And this is also greater for Black women, yes. And it does come down to also health literacy. I think we often, as clinicians, forget that our education in these topics is so much higher than the average patient who may have, at best, a high school education or doesn't really truly understand what they're reading or hearing from Dr. Google. So we need to somehow change the system and try to make them more health literate. And we need more time to be able to do that sometimes instead of every 15 minutes for a visit. With that, I know I'm past 11:30. I guess I'm gonna stop share, I guess, and let Tama take over if she can.
Not a problem.
Not a problem.
So much, Dr.
So much, Dr. Berger.
I'm sure we're going to continue the conversation next year. As indicated, this is actually going
There's actually
to
mandate a
CME starting
for CME starting
anyone, OBGYN,
OBGYN
who are pregnant,
who are pregnant
provide more information
will provide
once
more
the law
information once the law
clear.
becomes clear.
Otherwise, thank
Otherwise, thank
Dr.
you so much, Dr.
Berger and
Berger and
everyone at our keynote
right now.
section
So right now, so I'm
to
trying
the next room.
to the next
Thank you
room.
so much.
Thank you so
Okay.
much. Have a
Great.
great day.